So I'm talking about hypertension today, managing resistant hypertension. And I think we know that hypertension is a primary care problem, and most of the patients with hypertension are actually managed by yourselves. So I'm sure you all have more experience in me than in managing hypertension. And we also have a cardiologist here and a nephrologist who are also experts at managing hypertension. So I will not share on everything in hypertension. I don't think we can manage everything, but I'd like to talk about aspects of hypertension that I'm interested in, that I know a bit better as an endocrinologist. So managing anybody with difficult to treat or resistant hypertension, the algorithm that we use is always the same. The first thing we always have to think about is compliance to medications. That's clear in whichever patient. The more medications you put on a patient, the more likely they're going to be non-compliant with it. If they find that it doesn't work, they're taking 3 or 4, then they will start questioning, is there any point taking another one? So that's something that we really have to think about. White coat hypertension. A home BP is always better than an office BP. I'm sure you realize that as well. After the first reading, it's high. The second reading is always not as bad. And maybe the third reading, it comes down. So white coat is something that's very difficult to know unless you actually have a patient looking at his blood pressure at home. An ideal situation is really a patient should be very aware of his blood pressure at home and know what the targets are and be looking to you then for help of medications if needed to control. And then once you rule that out, we start looking at secondary causes for hypertension, which are important. If medications have not achieved its effect, then we have to think a bit harder about secondary causes. And it doesn't have to be just a young patient, it can be any age of patient. For renal causes, renal artery stenosis, this is not something that will be easy to diagnose in a clinic, but things like glomerulonephritis certainly can be. Every clinic will have a urine dipstick to look for microscopic hematuria. It's something simple, cheap, and easy to do that should be done. Chronic kidney disease is probably the most common cause of hypertension for secondary causes. Coarctation of the aorta, simple examination, radial femoral delay is always crucial. And then it comes to endocrine causes. I've got pheochromocytomas because it's not common, but it's very serious and of course potentially fatal if it's left undiagnosed. So that's why I use a pathological slide here, because you don't see signs, but they do have symptoms. So patients classically paroxysmal headaches, sweating, and palpitations. Now, everybody with a real pheochromocytoma should have these symptoms. So these are very, very sensitive for picking up the patients. However, not every patient that has periodical headaches or sweating or palpitations has a pheo. So these are still exceedingly rare conditions. We're starting to see more with adrenal incidentalomas. And the test that we use is 24-hour urinary metanephrines. And if you ever do want to send it off, it is possible. You can send it to the National Reference Lab. It's about $150. Not the first choice, but I mean, if you really suspect this, and this is negative, then you are very certain that this is not the case, because it's 99% sensitive. Triggers, beta blockers can trigger off a pheo crisis. Tricyclic antidepressants, MAO inhibitors, even a common drug like metoclopramide can also precipitate a pheochromocytosis, cytoma crisis. And what was once thought to be a 10% disease, 10% hereditary, 10% bilateral, and 10% metastatic, is now recognized to be more commonly hereditary. So for example, 2 patients present to us in a space of a month. The first one is a 27-year-old lady with very classical symptoms. We actually did a functional scan, and you can see two lesions, one in the high level of the kidney, a higher level of L1, and much lower down, another paraganglioma, and also a head and neck tumor on the right side image. So she had an SDH mutation. And the one below, classical patient with hypercalcemia, also having pheochromocytoma symptoms, and she had bilateral pheos with the MEN2A mutation. So the adrenal glands are actually very important glands for hypertension. The inner medulla secretes catecholamines, which produces pheo. The outer cortex produces cortisol. In excess can produce Cushing's. And my area of interest is aldosterone, which leads to Conn syndrome. Just a recap of the renin-aldosterone system. In a patient with a aldosterone-producing adenoma, you produce excess aldosterone. This will lead to salt retention. And salt retention will then have a negative feedback onto the renin and then the renin secretion. So renin will be low. So patients have a high aldosterone and low renin. And this is a very, very useful marker. This ratio, a high aldo and low renin, will give you a nice ratio to screen patients for primary aldosteronism. So a high AR is very, very sensitive and very useful for picking up patients with primary aldosteronism, or PA for short, which I use from now on. So when Con described this, Con refers to a unilateral PA, so it's only on one side. And he described patients with hypertension, hypokalemia, and adrenal nodule. What we now know about this condition is that it's not as uncommon as it used to be thought. 5 to 10% of all hypertensive patients have PA. Majority of patients are actually normal kalemic, they're not hypokalemic, as once thought as well. And the original patient that Con described was a 4 cm adrenal tumor. But what we do know now is actually most of these tumors are actually 2 cm and below. So they can be hard to pick up even with our very sensitive high-resolution CTs. So is it really that common? We have 2 local studies to show this. The first was actually on the left in a primary care setting in 2000. They screened 350 patients in Alcan Polyclinic and another adjacent, I think, Ang Mo Kio Polyclinic. 350 consecutive patients with hypertension. And they found 16 patients, which is 5% of these patients having PA. And the age were not young. They were 55, mean age. 37% were hypokalemic, which means that majority are normal kalemic. And half of these patients actually had a unilateral PA, which means that if you do surgery, it can be potentially cured. A repeat study was done in NUH in resistant hypertension patients that were diabetic. And they found a prevalence of 13%. So in the first study on the left, within the primary care, 75% of the patients were actually controlled with one medication alone. So they are not difficult to control hypertensive patients. So it's really a very common problem that needs to be recognized and diagnosed early. And this prevalence is not isolated to Singapore. So in prevalence studies throughout the world, US, UK, the prevalence has always been about 5 to 10%. So I'll spend a bit more time on PA. This is a 54-year-old gentleman who came with acute pulmonary edema. They couldn't find a reason, so they blamed it on hypertensive heart disease. In the cardio clinic a few months later, he had a stroke and he was admitted. He was noted to be hypokalemic while on a hydrochlorothiazide. He was having resistant hypertension despite 3 or 4 medications. He required potassium replacements to maintain his potassium. So we did the aldosteronin, which was found to be high. And his CT scan did not find any adenomas. So who should we screen for PA? If the prevalence is 5%, then we find that the prevalence in more severe patients, it's higher. In more resistant patients, in patients with hypokalemia that's either spontaneous or diuretic induced. So if patients are actually normal kalemic, their potassium is 3.5 to 3.6, they're on the low end of normal. And you challenge them with a thiazide, and their potassium drops to 3.4. So they already have a propensity to develop hypokalemia. So we believe that you should not think about a thiazide-induced hypokalemia as just due to the thiazide alone, but these patients have a propensity to develop hypokalemia, and then they are even more likely to have PA. So if you have a chance, if you see a patient like that, then that will be another red flag to actually think about screening these patients. How do we do it? We always try to correct the hypokalemia, because if the protein is still low, then they may have a falsely low aldosterone. So we do it in the morning, 8 to 10 o'clock, renin aldosterone levels. They should be always off spironolactone, which is the treatment for PA, and that will derange your aldosterone-renin ratios. There are other medications that can alter the aldosterone-renin ratio as well. But because prevalence is 5%, and we say that we have to stop medications before screening our patients, then out of 1,000 patients, most people are not going to screen any more than 10 patients, for example. So it's much better to screen more of your patients and pick up the more severe ones than to not screen anybody at all. So now, in most guidelines, we actually, in our current practice, we actually do not recommend stopping other medications apart from spironolactone for 6 weeks. And this is the renin results and aldosterone results that you will see. All aldosterone-renin results are actually sent to NUH currently, except for SGH. So all the restructured hospitals and all the GPs will send it to NRL. And currently, they're actually sending it to Mayo. There has been an issue doing it in-house in Singapore for the last year. So they've been sending everything to US Mayo Labs. It doesn't mean extra cost to your patient. The extra cost is actually borne by NUH, but that way you actually have reliable results to depend on. So the reference ranges hasn't changed. We've been talking about changing it for the last year or so, but currently it's still the same reference range that you see here that I printed out. So in this patient, the CT scan was normal, and the problem with CT is that it doesn't pick up very small tumors, and it can also pick up incidentalomas. So in 50-year-old patients, 5% will have an incidentaloma. That's completely non-functional. It doesn't make a difference to the patient, but it makes it difficult for our diagnosis. So CT scans are actually inaccurate in 50% of patients. What we do is adrenal vein sampling through a catheter. Intervention radiologists will actually use IR guidance to sample and put a catheter into the right adrenal vein, the left adrenal vein, and they get bloods out, and they compare the aldosterone levels on both sides. So in this case, you can see the left side in red color at 17.8. It's much higher than the right, 0.4. Anything more than 4 times is considered lateralization. So what we think here is small adenomas that cannot be seen on the CT, and that is responsible for the aldosterone excess. This is invasive. It is very difficult to do. In most centers, the failure rate is actually 50%. So if you get a result on the right side without the left side to compare, it's as good as not doing the procedure. Fortunately, we do have a good IR doing this with a 100% pass rate over the last 3 years. So in this gentleman, he went for adrenalectomy. A few things to mention. PA is associated with higher risk of end organ damage. So aldosterone is actually toxic to the heart, to the kidneys, to the brain, and it's not surprising that these patients have many complications, or even above the hypertension side effects of aldosterone. So like I mentioned, hypokalemia due to thiazide, do not completely discard it. Resistant hypertensive patients should be considered. And what we expect after surgery, these patients are cured of PA. They are always cured of hypokalemia, but hypertension is not always cured, because on top of essential hypertension, which is common, 1 in 4 adults have essential hypertension, they have primary aldosteronism, which makes the blood pressure even higher. So when we correct that, what we expect is sometimes to see they have back the essential hypertension that is much easier to control. In addition, when a person has hypertension for 10 years and more, there's a lot of vascular remodeling that makes some of these changes irreversible, and subsequently the hypertension can be irreversible in some ways as well. But they have significant improvement. If you can see, the blood pressure improvement can be about 20 to 10, which equates to about 3 or 4 medications of blood pressure medications. And CT alone is not the ideal imaging or choice of workup. So this is our intervention radiologist who has joined me overseas, and he has come back with a 100% success rate, like I mentioned. So we have, in the last 2.5 years, we have diagnosed 18 patients with unilateral cons, 7 Fios and Cushing's as well in this short space of time. So secondary causes of hypertension are not uncommon. Moving forward, this is a future state-of-the-art functional scan. So avoiding adrenal vein sampling, we're hoping to do this metomidate scan. It will actually light up the site of lesion. In this case, you can see the right side clearly lights up much more than the left, even though they're bilateral nodules. So this is non-invasive, not operator-dependent. This would be ideal kind of test that we can do to pick up these patients without putting them through an invasive test. So this is the results from Cambridge with Prof. Maurice Brown. And this is our own study that we have got a grant. It's a national grant, and we're actually going to do this test in all hospitals. So all the hospitals actually collaborated with us to do this test. And we hope that this will be available in a couple of years' time as clinical practice. It will be available as a research option. So as I was talking about this system, if you look back at blood pressure control, now I'm moving away from PA and cons. Blood pressure is actually a factor of cardiac output and peripheral vascular resistance. So cardiac output is really volume times resistance will be vasoconstriction. So on the right-hand side, you see sympathetic system stimulation, renin, really controls vasoconstriction. And on the left side, when you have a person who is salt overloaded, volume overloaded, it's a completely different state. So patients who are volume overloaded and salt overloaded, the renin will be suppressed, whereas on the patient on the right, they will have a high renin levels. So renin has been purported to use to stratify treatment of hypertension for many years. And if you use medications like A and B, A's, ARBs, or beta blockers, you block the renin side. And whereas you use calcium channels and diuretics, you block the volume. So A and B combined with C and D will be ideal. And John Arash, who has passed away 2 years ago, has done many studies on this since the 1960s. On the left side, you see patients with treatment with an anti-volume drug, so a diuretic. And the patients with a low renin responded much better in terms of the blood pressure lowering. On the right-hand side, patients were treated with a propranolol. The patients with high or middle renin responded much better. And this was subsequently supported in a very recent study the Pathway series from Prof. Maurice Brown in Cambridge and other collaborators. So they randomized patients into treatment with either a ARB or a diuretic, and then they combined some of these patients later on, and some patients went straight into combination therapy. And in the red color, you can see patients with combination therapy will have the maximal effect in terms of drug lowering right at the start, and that will maintain later on. In the patients with the blue and the cyan colors, they were given hydrochlorothiazide and losartan, and they didn't have so much improvement at the start, but later on when they added the other medication, the maximal effect was seen. So it illustrates 2 points. If you want to bring down the blood pressure quickly, you can use a combination therapy. The second thing is that if you start with a patient on one medicine first, you don't have to be worried about the other axis being overstimulated and failure of catch-up. So that was at a point in time, some people were saying that if you block the renin secretion, then you will stimulate so much volume that no matter how much volume drugs you try to give later on, you can never catch up. So in this case, this kind of study kind of showed that it doesn't matter. You can always start one medicine first. It doesn't improve, you can always add the second one, and the blood pressure lowering effect should still be there. The second thing they looked at was to look at personalization of medicine. So looking at renin levels, on the right side you see the patients with high renin, and the patients with high renin, losartan had the best blood pressure lowering effect compared to thiazide. And right at the bottom is the red group when combination therapy was given. So of course, if you don't think about renin, then you can just give combination therapy. You always get the maximal effect either way. The NICE guidelines in UK have always been, well, they have been using this for more than 10 years, and they recommend in patients who are young, it's usually renin driven, so they will recommend A. And patients who are older, or African patients, then they're usually more sensitive to calcium channels or diuretics. And if one doesn't work, then you add both. And if two don't work, then you add a third one, ACD. And after that, that's considered resistant hypertension. So this is resistant hypertension pathway 2. So it's another study that the same investigators did. And with the ACD, it's still not controlled, they actually put patients through a cycle. So patients did not know what medications they were on, but they went through all 4 cycles. So a placebo arm, bisoprolol, spironolactone, and doxycycline. So every single patient had to go through all 4 of these treatments without knowing which treatment they were on. And what you can see is right in the middle, this is spironolactone. So spironolactone was the best in lowering the systolic blood pressure. And that's what is evidence-based medicine. So we know as a fourth-line medication currently, spironolactone, at least in this Caucasian population, is the best line of medication. And then when you talk about personalized care, which patient will do better? And then this is where renin comes in. You can see a renin graph at the bottom. This is a log normal distribution of renin. So patients with high renin actually have very, very high renin levels, and the patients with low renin have very low renin levels. And in the red line, you can see spironolactone. The blood pressure lowering effect was not so remarkable on the right side with high renin patients, but when you came to the low renin patients, then you could see clearly spironolactone was very, very efficacious, lowering the systolic blood pressure by about 18 millimeters mercury in these patients. And the dose used for spironolactone was 25 to 50, and this was on top of using ACE or ARB, which if you think about, there's a risk of hyperkalemia. So these patients had normal renal function, a renal eGFR of more than 45. But it was not associated with increased risk of side effects. So this is the side effect profile. Potassium of more than 6 was only 2%, so 6 out of the 285 patients had one episode of potassium more than 6. So you have to monitor the patients. It's not a side effect is not there, but it's still generally safe. So I'm going to move on to, so why does it work in resistant hypertension patients then? So we have actually blocked the renin, we have blocked the calcium channels and diuretics, we have blocked salt retention. So what we haven't blocked actually is aldosterone, because aldosterone that is autonomous from the adrenals. If there's some kind of aldosterone escape, then this will not be blocked. And aldosterone will then work on the different part of the kidneys, separate from where the thiazides work, on the distal convoluted tubules to increase salt retention, increase water retention, and that can bring up blood pressure. So it's probably this aldosterone escape mechanism, or primary aldosteronism as well. So primary aldosterone is a common cause in resistant hypertension patients. Some of these patients may be undiagnosed cons as well, which is why spironolactone is particularly efficacious. So we were hoping to move towards renin measurements with direct renin, which is less laborious. But like I mentioned, This is not available currently, and NUH is still looking to bring it in, hopefully. If this is in, then you have actually results that can come out in a matter of a couple of hours, and this is much more clinically applicable for use. So we do have a Changi-resistant hypertension clinic that's just been started with the cardiologist support, nephrologist, endocrinologist, internal medicine, and the pharmacists are running together. So every week we run this, and I have to acknowledge all these names here, including Alvin, who's going to give a talk after this. They've been very supportive in putting this resistant hypertension clinic together because, as you know, hypertension is a common condition, but it's not very clear if you have a resistant or difficult to control diabetes patient. It's very clearly endocrine. But if it's a resistant hypertension patient, then who do you send it to? Cardiologist, a nephrologist, endocrinologist. So we do have this clinic together, and we carefully work out the patients for all the secondary causes that I talked about. And we also try to even if it's not a secondary cause, of course, we have to manage it with the pharmacist in a multidisciplinary approach. So take-home messages, it's important to consider secondary causes of hypertension. PA affects 5 to 10%, of which half of these patients have a unilateral cause, which means surgery, removal of the adrenals can actually cure these patients. We will suspect them if the blood pressure is high, treatment-resistant, hypokalemia associated. What we use is a high aldosterone-renin ratio to pick up these patients. And low renin predicts a response to volume treatment. So it doesn't just mean spironolactone. I have to remind myself as well that low salt diet is actually very crucial. So if you think about it, these patients are actually on calcium channel, a diuretic like a thiazide, and then you still need spironolactone, which is another diuretic. So in some ways, it's just a reminder to ourselves that the current salt that we take in Asia is a lot higher than the recommended salt intake. And not just a diuretic, but we also have to think about stressing to patients that they have to consider reducing their salt, because that's another important element of resistant hypertension. Thank you.